This is a case who presented to us with a severe corneal opacity and a secondary hyaline degeneration and a visually significant cataract. We did not want to perform a corneal transplant on him, but decided to go ahead and just handle the cataract as such. And this is how I am going to show I deal with such cases. Few basic principles one has to observe, and these cases usually land up with pretty good vision. You don't have to actually do a corneal transplant for them. So initially, after making two side port incisions, I go ahead and stain the capsule with trypan blue, which I expel with 2% HPMC. Make sure there is a complete fill of HPMC within the chamber. I then put some HPMC over the cornea for visualization and watch carefully. I am starting the rhexis from the seeing area of the cornea. I am not going under the opacity initially because that would be very difficult to control. So once you have a sizable flap, it's very easy to visualize, even if you cannot really do so where the flap is. Go on the underside of it and keep making a shearing force and bringing it around. And there, once you see the flap, it's much easier, and I've got a fairly decent rhexis. This is more than adequate. I haven't put my main incision because in case I had lost the rhexis, then I would have done an SICS. I'd probably gravitate towards an SICS. Now watch how I have done my keratome incision. It's not very large. Be very careful. Do not make a very large initial incision, as that would get hydrated and further give you trouble with visualization of the intraocular structures. I then make sure I do a very adequate hydrodissection. Make sure your nucleus is completely free. Check the rotation both with the tip of your hydrodissection cannula. Put in some HPMC and rotate it with a Sinskey hook. If I had known NATO earlier, I would have really rotated this nucleus to free up all the cortex. And then I take my phaco and a sharp chopper, and look, I am going towards the periphery to impale the nucleus because that is where I can see it. I have impaled it somewhere in the center, and then even my chopping is done under visualization. So keep it in the seeing area and watch the phaco needle. The phaco needle is well within the chamber. Make sure your infusion ports are within the anterior chamber and not within the incision. If that happens, the incision will get hydrated, and what little visualization you have on the upper part of the cornea will also get compromised. So these are the few basic principles that you just have to follow. Don't be in a hurry to take out small fragments. Make sure you have got enough chops. And these chops should be as complete as possible. You don't want a bowl in such a case. And keep rotating and keep chopping. And there I've got a good segment. Once I have that, I know it's pretty easy for me to get out the rest. You need space within the bag to further manipulate, and I have more than enough space. Now do not turn your phaco needle to an inaccessible area. Just come out, be patient, put in viscoelastic and rotate using two Sinskey. In this case, of course, I've got one chopper in one hand. You can have two Sinskey hooks and rotate your nuclear fragments to a more accessible area. In this way, your phaco needle can stay well within the NT8 chamber and you don't have to move too much, and you can actually phaco and eat up the fragments, visualizing everything. You don't want the situation where you suddenly find you're not able to phaco because vitreous is in the phaco needle. And once the segments are done, I go ahead with my bimanual. It would be a good idea to increase your bottle height so that the PC is well behind. Try not to go with very high parameters, especially your outflow, because since the visualization is so poor, you will not even notice if you have got your capsule in your port. And don't do heroic things like turning your port posteriorly. Just come out and go from the other side. If you keep your port anteriorly, you can even go under the opacity towards the periphery and slowly bring out cortex. Just try to go down, hold on a little bit and pull it towards the center, but pull it very gently. Because your parameters are so low, it's unlikely it will pull out the capsule. And once all the cortex is out, or most of it is out, go ahead and try to inject your IOL directly into the bag. So this would be a single piece foldable IOL injected directly into the bag. You may see some cortex, you may have left some cortex. It doesn't matter. It will hydrate and it will show up, and sometimes you may even have to take them up for a small cortical aspiration the next day. It doesn't matter. As long as your PC is intact, your lens is in place, the job is done. Thank you very much for watching.